Boy, everybody sure got quiet. First, let me say that I'm not John Auerbach. I'm hoping you already knew that. I'm Mary Currier from Mississippi, and John couldn't be here. So I get to moderate, which of course you can see is, yes, thank you, thank you. I'm very comfortable up here, just so you know. So let me start out by saying that health and wellness can be communicated in a number of ways, and we all need to learn to communicate that in whatever way our audience can understand. So it's very important to learn those communication skills. As public health leaders, we're tasked with communicating with all kinds of folks about the value of prevention, how investment now can lead to both short and long-term health improvements for our citizens. And this is timely, okay, y'all know I'm from Mississippi, as obesity rates continue to rise and chronic disease and injuries contribute to more than 1.8 million United States deaths and cost our nation over 1.7 trillion in lost productivity and healthcare expenditures. So modifiable risk behaviors like tobacco use, poor diet, physical inactivity, alcohol consumption, and drug abuse, although I could use a little alcohol right now. Sorry. Yeah, sorry. Remain major contributors to U.S. mortality rates and have a significant impact on our health, our economy, and our ability to be a competitive workforce. I think the workforce part of this is very, very important. As a nation, it's imperative that we work together to create a healthcare system or a public health system that coordinates prevention from the community through the healthcare system, the delivery system. So state and territorial health agencies are strategically positioned to provide leadership to develop, coordinate, and implement comprehensive, evidence-based approaches to wellness and preventing debilitating chronic diseases. It's essential that we work with our partners, both in the public and private sector, and with policymakers to promote public health and an environment that fosters healthy living. This session focuses on research findings and on return on investment for community prevention in terms of limiting healthcare treatment costs, improving quality of life, and increasing productivity. Our speaker today will not only discuss the research to support these prevention strategies, but he'll frame the value of prevention in a manner that resonates with the private sector, something that we've not really had to do for a very long time. And to help us understand how to communicate this with policymakers and to use this information and involve stakeholders. So Dr. Jim Marks, is a Senior Vice President at Robert Wood Johnson Foundation Health Group. He directs all programs and administrative activities in that health group. This includes the Foundation's work with childhood obesity, public health, and vulnerable populations. He's particularly qualified to do this. Prior to joining Robert Wood Johnson Foundation in 2004, he retired as an Assistant Attorney General. And before that, he served as CDC's National Center for Chronic Disease Prevention and Health Promotion Director for almost a decade. So I've been hearing his name for a long time. Throughout his tenure at CDC, Dr. Marks developed and advanced systematic ways to prevent and detect diseases such as cancer, heart disease, and diabetes, to reduce tobacco use and address the nation's growing epidemic of obesity that I think Mississippi's the epicenter, right? Dr. Marks has received numerous federal, state, and private awards, has been elected to the Institute of Medicine in 2004, and has served on many government and nonprofit committees devoted to improving the public's health. So, Dr. Marks, it is all yours.
Thank you, Mary. It's a real pleasure for me to be here. And for those of you who don't know, and maybe Mary didn't, when I first went to CDC in 1980, my first consultation was on maternal and child health, infant mortality to Tupelo. And the local health officer, the district health officer then, was someone also known to many of you, Earl Fox. And so it was great fun to work with Earl and great fun to go to Mississippi. I've had a good fortune today that I don't often get, and that is to sit through a number of the presentations. Sometimes I'm one of the people having to go catch a plane or go somewhere else. And so I was really impressed with the discussions that you all have had before I got here, or before I got to the podium. When David was talking about the challenges that Texas is facing and all that he's been working on, and he said a lot of the statistics that I might have used, some of them, his were Texas specific. I might not have used Texas, some of them were national. I also had heard the discussion before about the IOM report and the notion that health and healthcare need to work together more closely. Make no mistake about that. That was one of the themes that I would emphasize, I will emphasize. You should also know that one of your alums, Eduardo Sanchez, we had come and review our public health program with several others. And one of their big recommendations to us was, even though we're very clear that we do both health and healthcare, to look for ways to integrate across those areas and to help bring them together. So that is one of the things we now think of very clearly as a foundation. I've also been impressed that the sessions you've had, you're facing a lot of real challenges, fiscal being probably the ones that that keep you up at night, and then the crises. But all of these talks are really about really big picture issues. I hope to continue that to a degree, but I commend you for having that kind of perspective. And you heard from Dr. Shah that he and I had talked earlier this morning, and how he is thinking. He's in a unique position, but how he is thinking about how Medicaid can help support public health. So I'm really honored to have been asked to speak with you today. I know how difficult it's been for many of you, and yet how committed you are to the purposes that you have. You, your predecessors, and your professional descendants are the leaders that our people depend on to speak and advocate for protecting and preserving their health and the health of those they care about. I'm not going to spend a lot of time telling you about what the foundation is doing and what our work in the areas that I have responsibility for, or the others. If that comes up in the Q&A, I'm happy to talk about it. But one area that we did a lot of work on is there is a way of doing message research to say what will resonate with the audience you're interested in. And we've spent a lot of time, some of you may have seen it, looking at how social determinants and social factors affect health, but how to make that relevant and acceptable to those that come from very different backgrounds. Then it was largely policymakers on both sides of the aisle. One of the things I think we came away with was, in fact, there's a lot of room on both sides of the aisle. Now, I'm going to start off with this quote here, and you can see from this article that was in the Lehigh Valley, that's what LVB means, Lehigh Valley in Pennsylvania. In an effort to lower steadily skyrocketing healthcare costs, employers are closely examining the health of a geographical region before deciding to set up shop and call it home. And then there's a quote from a vice president of a company. We do always look at the health of a region, said Rena Sharp, vice president of Westport Axle Corporation in Louisville, Kentucky. This was as they were deciding to build a new plant in the Allentown area of Pennsylvania. They had other reasons. It was not just health that they chose that area, but where they chose in that area was influenced by health. I'm going to spend some time talking about how we've got to make this relevant for the business community. So I'm going to do a little role playing. Even though there are 3 empty chairs here, I am going to channel my own little Clint Eastwood moment. I know it's late in the day, and I can give you facts, and they'll be facts, but we'll start with this. Now, imagine that I'm a state health officer calling to the governor's policy person. I use that my title as State Health Officer, because I know that as you listen to me, you'll all be able to figure out how to do it so much better. Please do it better than I will. But hello, Bill. I was just at the State Health Officers meeting, and there was a buzz about how businesses are using the healthiness of a state or a community to decide where to expand. Other governors and mayors around the country are talking this up. We heard about a company building a plant for 500 employees using health to help decide where to locate it, and that was in Pennsylvania. It was not their only reason, of course, but it really was influencing where they chose to move in that area. Business professors are hearing that businesses are using obesity rates in town as one of the elements in their decisions, because they know it'll affect their health care costs and their employee productivity. Governor Branstad of Iowa has a very public push to make his state the healthiest. And businesses like IBM chose to move there because they had low health care costs. Governor Daniels of Indiana, in his first term, found that as he tried to lure business to Indiana, that they had high health care costs. And they had a lot of other good things that he could say about the state. But he was so concerned about health care costs that he set up an insurance program for low-income workers that emphasized prevention and provided first dollar coverage. And he also strengthened their tobacco control programs. Now, he was the head of OMB and the head of Eli Lilly. He knows his way around a balance sheet. And the story is that the big VW plant that just opened in Tennessee chose the Chattanooga area because it was among the healthiest communities in that state. And in Maine and elsewhere, businesses are listing medical care costs as their #1 issue. Even Mississippi, for crying out loud, where we all feel good about comparing ourselves to, is getting into the act. The Blue Cross Blue Shield started an award program for the healthiest city. Hernando won their first award, and it apparently is about to get its first manufacturing business to move there in decades. Tupelo won the award this year, and the state is talking about that they've just seen a reduction in their childhood obesity rate statewide. There are also a lot of new reports showing that the economics and health benefits from staying healthy are even greater than people thought. For example, California saved about $86 billion in health care costs from their tobacco control program. That's real money. Of course, they got those reductions because they had had large reductions in heart disease and cancer and other conditions due to tobacco. Our state's population of 3.5 million is about a tenth of that of California's. So maybe we could expect savings of $8 billion. And clean indoor air laws are leading to lower heart attacks almost immediately, and those rates stay down. There's even more data now that people who didn't smoke, kept their weight down, and stayed active delayed becoming disabled by 7 to 10 years as they got older. This could mean we might be able to help slow the growth in our future nursing home costs if we can get that to happen here. To make a very long story short, we all know that the governor's top priority is to get more jobs to the state. I think we can showcase health of some of our state to help our state too, like the others are doing. I'd like to get together with you and the state's economic development people and talk about some ideas and see what we can put together. I bet we could get the Blues to do a similar kind of award here, and maybe even get the Chambers of Commerce to co-sponsor as a start. We can talk about what else might help that wouldn't be too expensive and would pay off as quickly as possible. Thanks. Let's talk more when I get back. Bye. That business quote, now I know, by the way, you might not have that call with your governor's chief of staff or policy advisor, but you could because of all that's happening. When I had discussions with Paul and Lacey and Mary, forgive me, Mary, for that reference to Mississippi, in preparation for this talk, I wasn't quite sure how to frame it. You all already know the importance of public health approaches and prevention, both clinical and community. And you generally know the data. And we couldn't give you enough of the recent science in a short talk to make much of a difference. So what we felt would be the most helpful would be to think about how to talk about prevention and public health regarding its health and its economic value and from the perspectives of what your boss's top priority is, economic development. Now, maybe my call with the governor's policy lead was a little over the top. Obviously, I did it to make a few points. First, the private Business concerns about costs and interest in health is real. It's a top concern, influencing their fundamental business decisions. And you probably know examples from your states more than just the few I mentioned. But I want to be clear, I only mentioned a few that I know of. This is more than an anecdote here or there. This is something that is happening around the nation, and we ought to be fanning those flames and putting public health, health prevention into the middle of those discussions. Second, the science is strong, and the actual value of being healthy on the bottom line is greater than most people realize. That is, most people outside of this room. For example, a not yet published study estimates that a 1% lower tobacco rate in a state with a population of about 3 million is worth almost $300 million per year in economic benefit. I use the state of 3 million because, in fact, that's probably closer to the median of your size, and it is also 1% of the U.S. population. Another study we funded by the Campaign to End Obesity on the costs of obesity found, they turned up actually, a study by the Society of Actuaries whose estimates were almost twice as high as those we use in the healthcare community. They felt that the costs of disability and lost productivity were actually much greater than the health sector's estimates. The actuaries are the ones the CEOs turn to as they think about their future costs. Let me give you an example right here from Texas. A report published last year by the state comptroller found that the cost to Texas businesses from obesity was an extra $9.5 billion in 2009. More than $4 billion for health care, $5 billion for lost productivity and absenteeism, $300 million for disability. That analysis estimated that if current trends continue, the cost could triple by 2030. So my message to you, the most important one, is that we need to place health right where it belongs, in the middle of the governor's top priority, economic development. And this is not just important for each state, it's central to our nation's economic competitiveness. What can prevention and public health bring to the table to solve the healthcare cost crisis, and yet not to oversell it or overpromise? That's a tough balance for us to walk. So before I go on, you know, I'm going to put some slides up. Some of them are going to be references from papers. All of the slides, my remarks if you want those, and the papers will be on the ASTHO website. Many of them are already there, so you can go to them if you're interested. My goal is to help you consider how to have these discussions with your governor or your legislature or the business community or your local civic leaders. It's a crucial challenge we have in public health because it is so normal for people, even policymakers, to think that good health is principally to be found within the doctor's office. And that if policy leaders can only talk about medical care, and all they can talk about are the bad news because it's all about high costs. But you and the governor can frame things as getting good health as actually a positive opportunity and an asset to build on for families, for a state, and for businesses. That's good news that the governor can use. And we all know that what they like is to be able to be proactive in a positive way. It's the repair work after the damage has occurred that are the excess costs that we call medical care. But before I talk about these issues, let's remind ourselves really quickly about the context about where we are as a nation, because I think it gives your role to elevate prevention's prominence in your state a special urgency and a cogency to the argument we need to do to prevent more disease and injury. David touched on it, some of the other speakers have too, but let's go through this. First of all, and we couldn't have had a better example than the one from Taiwan, they have an income that's half ours. They spend half of their gross domestic product on medical care, and they live longer. That's the story everywhere. Very bluntly, the medical care system we currently have and that our health care providers must work in is failing us. And any statement to the contrary is no longer credible. And it's becoming the biggest issue in our country's global economic competitiveness. We spend about $8,000 to $9,000 per person per year on health care, while the average of the other developed countries is closer to $4,000, 200% more. And of course, the developing countries that are growing the fastest spend far less. Now, there's a lot of talk about our national debt. Our public debt in aggregate is about $15 to $16 trillion, about equal to 1 year's gross domestic product. The other major commitment that people talk about that's not part of the national debt is the shortfall projected for Social Security, about $7 trillion. Only recently have people started to notice how much we've committed to our citizens in Medicare. The shortfall estimate here from several years ago is $34 trillion, dwarfing the rest of the federal debt and Social Security combined. Now you can see why it's becoming a central part of the national debate. This is so large, we will not solve it by tinkering around the edges of our medical care payment rates. When we look at how we compare to other nations, Taiwan, as I said, being a good example, we're number one in hospitalization for diabetes. We're number one in the principal cause of diabetes, adult obesity rates, among developed nations. I think it was David that had where we were overall, but we're number one among developed nations. And a recent Institute of Medicine National Academy of Science report says high obesity and high tobacco use rates and their health consequences are the largest causes of our nation's decline in global ranking and life expectancy over the last 20 to 30 years. Combined, they account for about 2/3 of that decline in global ranking. Now, we're now 20-something in life expectancy among developed nations. We might be able to justify our high medical costs if we had better outcomes. We don't. So despite a tremendous increase in costs for medical care over the last few decades, in fact, an increase of over $1 trillion in the last decade alone, more than any other country in that increase, other countries are getting healthier faster than we are. Our healthcare cost problem is so serious that almost all of the leaders in our nation will have to think about how their work affects health and healthcare costs and is affected by them. The link between our medical care costs and our future economic development and prosperity are that strong. Now, why should I give you, our state leaders, this national picture? Because actually your problems are worse. Your states can't run deficits. And because we have to embrace this crisis, even though you're in a difficult time, you've heard, we have to recognize that this is probably our best opportunity to truly make the case for public health and prevention, to claim our place in helping the health of the nation. The state share of Medicaid, you all know, it's putting all the other budgets at risk, with the fastest growing being the cost of nursing homes. When we take that into account, plus the state and local commitments for health insurance for employees and retirees like police and firemen and teachers and other workers, the cost of the states reach about $500 to $600 billion a year in aggregate. So let's think of that at about $2 billion for every 1 million you have in your state's population. Of course, it varies with your age distribution, what you pay for procedure in Medicaid, your Medicaid match rate, et cetera, but that's sort of the ballpark. I'm going to try to highlight some other places where the state fiscal issues are important as I discuss things, and try to take the national data down to the state. I believe that the most underutilized strategic opportunity that a governor can have as a positive policy direction is what we can do to have less disease than we do now to take care of and pay for. Almost all the others are negative. Who do we cut and how much? So can we prevent disease, or at the very least delay onset and seriousness to much older ages? Prevention is much more than what happens within the medical care system, though that's important. It's also what can we do outside or beyond medical care. And I want to be clear, prevention is not the only thing that will be needed to fix our nation's medical care crisis. We still need a lot of work in medical care financing, coverage, quality, and efficiency. And prevention won't always save money, but it's often cheaper than caring for the diseases and the injuries after they've happened. So think of it as often getting us better health at a discount. A few light touch definitions, just so that we're clear. Cost saving generally is framed as meaning it saves more in medical or indirect costs like work or disability than they cost. Only a few, even in prevention, meet this standard. Cost effective means it costs something, but it gives back a good amount of health per dollar spent. Many more preventive interventions meet this standard. As I said, think of it as good health at a discount relative to much that we do in clinical care. I also want to touch on something that had just come out recently. If you've seen Tom Farley's article in the New England Journal, where he looked at environmental interventions relative to in-person. He used the term and made the distinction, environmental versus person-directed interventions. Banning trans fats as a environmental, cancer screening is a person-directed. They found that more of the environmental ones, many more on a percentage basis, were cost-saving than those that are individual person-directed. Those might be cost-effective, but the more that were cost-saving were the environmental. Now, because of time, I'm not going to cover things that probably are pretty well accepted here. I want to talk about it somewhat differently. So I'm not going to talk about immunizations. They're one of the ones that generally is considered to be cost-saving. The data is the strongest, well-known, and probably reasonably well accepted, though I know that immunizations has had its own share of controversies. Cancer screening, breast, cervical, colorectal, cost-effective, that is at reasonable value. High blood pressure, cholesterol screening, aspirin prophylaxis, often good value, cost-effective depending on age and other risks a person has. Aspirin, some say, is cost-saving if the person is high enough risk. Many times, prevention interventions become less cost-effective when we go to people that are at lower risk. Smoking cessation, I won't talk about. Nicotine replacement therapy, quit lines, very often cost-saving, even when only modestly effective. They can pay off quickly, that is, cessation can. Pregnancy or prenatal care, I won't go down there. Nurse home visiting, you've heard already from Dr. Shah about that. Prevention of complications of disease, diabetic eye disease, amputation, kidney disease, generally cost-effective and very important, obviously, for nursing home needs. I went through this list, even though it is a list and sort of tedious. It's because there's a lot in prevention that we have something to say about and that in aggregate are really important. There are others that are well accepted, that are non-clinical, that make the case, the economic and the health case for a value, that I also won't talk about because of time. Injury is probably a key one of those, especially auto-related injury, now at their lowest level in decades. Seatbelts, airbags, crumple zones, DUI laws, designated drivers, et cetera. All very important. They have taken costs out of the medical care system. I'm going to concentrate on tobacco, physical activity, and obesity because they're so important for so many diseases that are among our most costly. Interventions can be clinical, community, or policy, and because they're often ones where some in the public have doubts regarding their effectiveness or at least a concern regarding how long it takes for them to realize value and savings. And public health often has an important role in those issues. So let's go. This is a slide from a study that said, what's the likelihood that a man age 50 would develop diabetes, heart disease, or stroke by age 65? Well, if he's active, normal weight, doesn't smoke, the chance is 11%. If he's a smoker, obese, and inactive, the chance is 58%, over a 500% difference in working age adults. If we had a drug, we'd put it in the water like fluoridation. The numbers are similar for women, shift to a slightly older age. Women live longer and they generally start off healthier. We've heard a little bit about this. This was the first study report on the diabetes prevention trial. It took people who were pre-diabetic, their sugar metabolism was starting to deteriorate, but they were not yet diabetic. Some were given a drug to see if they could slow the progression to full-blown diabetes. Others were given a moderately intensive counseling about changing their lifestyle and losing weight and becoming more active. The study had to be stopped because the lifestyle arm of the study was so much more effective, over twice as effective as the drug arm. It was unethical to continue. Over a 50% reduction in the likelihood of becoming diabetic over 5 years. How big a lifestyle change was needed? Lose 10 to 15 pounds, walk 30 minutes, 5 days a week on average. Real changes, but not huge. They led to big changes in likelihood of developing diabetes. Most people with health insurance would have had the drug paid for. None would have had the counseling covered until just recently. United Healthcare, the large insurer, decided to offer it to companies they insure. Just recently, the YMCA showed that its staff, with a randomized trial, could do just as well as the medical care system counselors and about a quarter of the cost doing it within medical care. For the first time, United Health agreed to reimburse a non-medical provider for a service like this. You might think about the Y as a partner. They're looking at other types of education that they can do. And now, in keeping with the age of ASTHO that we heard about, 70, I'm going to talk about healthy 70-year-olds. Does keeping people healthy so they live longer, doesn't it just cost more long-term in health care? Well, in fact, rather than use examples of specific diseases, this study showed that the lifetime health care costs of individuals who reach age 70, very healthy, without any disability, versus those who have any health limitation from a little to a lot. Those who get to age 70 in the best condition live on average 14 years longer, and their health care costs were $136,000. This was done in the late 90s, early 2000s. So these numbers are low. Those who had any kind of limitation lived only 11 years longer, and their costs were $145,000 lifetime. So the healthier costs about $9,000 less over their entire lifetime. Modest. But when looked at per year of life, the net difference is quite large. Almost a third, 32% lower in the healthy person per year. So the person who makes it to 70, still pretty healthy, does have a longer, more gradual slope of their health care costs than with a total that's lower, even though they live longer. Just what we would hope, since we know how much health care costs rise as people age. A more recent study using similar methods showed that the obese 70-year-old costs over 20% more, $39,000 over their lifetime in health care costs. So it was more recent, used slightly more recent data, and so their numbers came. Now let's look at another one, a New England Journal study on disability. Now this is a bit of a challenging chart. I'm going to walk you through it. The question is, do they live longer and spend more time in nursing homes? This is not quite that. It's the one I mentioned in my fake call. This study followed Penn graduates for over 50 years. They found that those who didn't smoke, this is now the yellow low-risk line, those who didn't smoke, maintained their weight, and were active, experienced the onset of disability, that is the difficulty, beginning difficulty in performing a major daily activity like bathing, etc., 7 to 10 years later than those who don't have those health characteristics. Now, I want to be clear, it's not that they needed to go to a nursing home, but that downhill slide in being able to take care of themselves starts 7 to 10 years earlier if they smoked, were obese, and inactive. So likely their need for real help in caring for themselves will also start earlier. Now let's look at it a little differently from your state's perspective. This was a study, this one's a little more dated. It's from the 1990s. Your states vary, still though, by about 100% in your death rate from coronary heart disease at age 75 or younger, pretty large. This study adjusted for the differences in risk prevalence between the states in smoking, diabetes, weight, activity, etc. About 60% of the differences between your state goes away. Most of the difference in premature coronary deaths are not due to how good your surgeons are, how good your coronary care units are, or how fast your ambulances are, but how healthy your people are to begin with. We've had a lot of discussion already about partners that you and your governors could call to the table. I've already mentioned the business community. There's one aspect I didn't mention. Most all the large companies are including strong wellness programs for their workforce. They wouldn't do it if they didn't think it paid off and relatively quickly. And there's pretty strong scientific literature suggesting these payoffs within 3 to 5 years. I will say that at least what we've looked at suggests that many of them are not using the programs that show the best evidence. There's not the same kind of evidence base, and the issue of fidelity to the approach is a serious one. But the main point is that business is realizing that it's to their advantage. I've already mentioned the why, but the United Way is also embracing this vision of the connection between community health and education and jobs. They are now a partner with us in our grants to communities called the Roadmaps to Health. I mentioned United Health, the insurer working with the Y, and the Blues in Mississippi, and heck, you've even got one of your own, Eduardo, here in Texas working for the Blues. Leaders in healthcare are also moving in this direction. You've got several sessions on it. Integration of health and healthcare is becoming one of the buzzwords also I see coming out of your meeting. In May, I spoke to the leadership of the Mass General Hospital. They've greatly expanded their community work and are looking to do more in population health. As you might expect, as with most hospitals, they think of what they're doing in community work as providing clinical care out in the community and not really the way we think of population health, but they're realizing they need to look that way. I found the Allentown business story when I was asked to speak about prevention and societal factors for good health to their largest healthcare system. And this November, the Association of Academic Health Centers is having a national meeting on what more they can do to address the community and social determinants of health that affect health in their areas. And if you haven't noticed, it looks like the New England Journal is becoming a public health journal. I mentioned Tom Farley's article, but just this week, let me read you the titles of the commentaries. What business are we in? The emergence of health as the business of health care. It's the first commentary. From sick to health care, re-engineering prevention into the U.S. system. That's the second commentary. And the third one was the developing vision of primary care, and their main point was extending care into the community, into the upstream determinants, the social determinants of health. We have a medical care system that's ready to work with us, with you. Now, I had touched in my call on a few communities. Civic leadership is thinking like this across the nation. Mayors from Oklahoma City, Hernando, Nashville, and others are taking on health in a broad way. You might be able to find some in your area that could embrace this with you. Let me give you an example of one that we have been interested in. Mayor Joe Reardon of Kansas City, Kansas. His county ranked dead last in Kansas in the county health rankings. He was stunned. He has the med school there. He has some of the best rated hospitals in the state there. He talked with their medical leadership. To their credit, they were not at all defensive. They said, we believe we give good care to those that are ill. But we have very little to say about how many get ill or injured and how sick they are when they arrive. The medical care sector became big supporters as he brought together the various city agencies, because they all report to him, including education and transportation, not just public health. He also asked the business community, plus the hospital and healthcare leaders, to come to the table. The city brought a supermarket into an area that didn't have one, began a complete streets policy with sidewalks and crosswalks whenever they renovate the streets, started nurse home visiting programs in their immigrant neighborhoods, to mention a few. These are all going to add up to a change in a culture towards health. I need to mention the National League of Cities. They approached us because they had so many mayors that wanted to make changes regarding childhood obesity. They asked us to support a web-based set of toolkits and examples so that mayors and city councils from around the nation could learn from each other and all could do more. Now, I've hardly spoken about your need for financial resources, even though I know what you've been going through. I hope my comments about what other health systems and mayors and businesses are doing helped you realize that the resource that is always in shortest supply and most crucial is leadership, especially leadership that reaches out for others to join with them, brings unusual partners together. We know that major health problems of our time, like obesity, like the chronic illnesses, won't be solved by medical care alone, by public health alone, or research alone, but rather by actions taken by leaders from many parts of our community, like education and private business and transportation, each leading where they can. Often the science about what contributes to good health will come from medicine or public health, but the responsibility and the authority to act are often outside of your agency's responsibility. Auto injuries is a great example. So can you lead where you don't have authority? Can you lead where you don't have resources is going to be a new big challenge for us in public health. You're going to have to encourage those leaders in education and transportation and housing in the private sector to think about what they can do where they have authority in policy and implementation, even if they don't at first glance realize that that's part of their role. Your best chance is to get the governor and the business community to see that a healthy business climate and a healthy state and communities are essentially one and the same. Our civic leaders and the public in general have not been nearly as aware that how our society is organized, what our policies foster or inhibit, what our communities encourage, or our institutions, public and private support, can be equally fundamental causes of good or ill health as are the biologic ones. Warranting study, warranting action to their impact on health. But they are certainly, those policies that is, among the leading causes of the distribution of disease and injury within our nation, within your states and your communities. Thus, good health in the state or community is important in creating a healthy business climate and a good place to raise a family. Real health leadership will become increasingly about much more than doing a good job of managing our organizations, your organization's resources or programs. Health leaders have to bring the important health issues to the attention of civic leadership at the highest level. Reversing the childhood obesity epidemic is a good example because it requires changing community environments, places like schools to become healthy places for our children with good food and opportunities to be active. Communities have safe and attractive places for kids and families to be active. These things will happen, but they will require the actions of leaders that are outside of public health, education, agriculture, food manufacturing, city planning, parks, etc. None of the actions or the sectors that I referred to is the direct responsibility of you and your agency or a hospital or the usual medical care system. I want to close by mentioning one last study published in Health Affairs about 2 years ago from CDC. The authors compared in a single model what would happen to health and to costs in each of 3 strategies: increased coverage, better quality clinical, preventive, and chronic disease care, and protecting health and promoting healthier behaviors with environmental and community approaches. In the first 10 years, they all increased costs and saved lives, with the quality and the community environment approaches being the better two. By 25 years, the community environmental approach saved 1 million more lives than any of the others and saved money, about $600 billion over that period of time. It was better than either of the other 2 in lives saved and was the only one that saved money. The authors conclude rightly that these 3 intervention domains are not mutually exclusive. In fact, they complement one another. That's the way we need to think. We heard that from Sister Kohn, that we can't go in with us having the answer and expecting them to make big changes. We have got to find a way to come together. So in closing, we're in a watershed time in our nation's history. We have to be honest with ourselves as a nation. Technologic advancement, where our nation's leadership is unquestioned, has failed to rein in the growth in medical care costs, nor has it even helped us have better health relative to other countries of similar wealth and development according to standard big picture measures of health outcomes such as life expectancy and infant mortality. Other countries, as I said, are getting healthier faster than we are. The fact is that the likelihood of initially becoming ill or suffering an injury, especially prematurely, is really about where and how you live, learn, work, and play. The likelihood that about whether a person smokes, what they eat and how much, if they're active, toxins or microbes they're exposed to where they live or work, the safety of their neighborhood. That is, community and societal factors that are beyond medical care. This must lead us all to conclude that the major disease problems of our society in time will only be solved when we reach out beyond our walls and when we help medical care do the same. What we really need isn't just more better treatment. What we really need is less disease. And in fact, without less disease, we are fast finding, and I think the medical care sector is starting to realize this, we cannot afford to provide good quality treatment like the best doctors we have can provide for all those who do become ill or injured. So even our hopes of providing good quality medical care for all those who need it is being put at risk by the excessive amount of disease we have. We face what could be the worst tragedy that I can think of. Our research gives us unaffordable solutions, and that's the spot that we're going down. If we can't have less disease, we won't be able to provide the best that research can for those who are ill. As a nation, we, and as leaders in a state, you, must think differently and look elsewhere for potential solutions to the connections between medical care and community health and all this implies. We've had an enormous imbalance where we've looked at a society for sources of health and illness and sources of disparity. I've tried in my time today to talk about how you can, and I think how we can help your leaders connect these bigger national and global themes to your state and to prevention and public health. That businesses are increasingly looking at a community's health regarding where to locate and expand, that the science regarding prevention effectiveness and cost effectiveness is strong, and that other governors, states, mayors, and cities are starting to act on this as well. Yours should too. Not just so you can compete successfully with other states, but so we can compete successfully as a nation. Thank you. Now I'll go fill one of those empty chairs.
You get to sit in the middle. Thank you. So, thank you, Jim. We appreciate the insights and the data, and like Karen Remley, this has added to the homework assignment. I think I have to go back and start reading the New England Journal again.
Not every article.
Yeah, not every article, okay, yeah. So Mel Kohn from Oregon and I get to react to Dr. Mark's remarks. And if I could have, I have just a couple slides, and who knows how they're going to show up because they're pictures. Okay, so we've heard how to frame prevention in a way that some of our policymakers and businesses might understand, and we've heard that there are businesses that are moving forward with that. So that's something that I think we get. I think we've learned about that today and a little bit prior to today as well. But one of the things that y'all may have gotten really quickly in your jobs and that took me a while is that perhaps taking the message to your governor, it doesn't need to be you. It might need to be someone else who's taking that message. You might need to just wind someone up so that they'll take that message and validate what you have been saying, or even take a different message. And what I have here, we didn't actually use return on investment, but this was something that was put together by our Public Health Association, and it was funded by a private health foundation to give to the legislature. And we actually, if you could go to the next slide, you can kind of see why the health department didn't want to take it. The Public Health Association was shaming the legislators into spending more money on public health in the state because of how little is spent per person on the state. You saw earlier that over 20% of most states' budget is state funds. In Mississippi, it's less than 10%. So we had a real struggle last year with our budget. We were worried that we were going to have a RIF, and the Public Health Association took this message to our legislators. So I think another thing besides how to frame the message, and you can go on to the next slide, how to frame the message is who takes that message, and it may not always be us.
Thanks, Mary, and thanks, Jim, for a very inspiring talk. It's always terrific to hear your perspective on things. It's always so forward-thinking, so thank you. Before I respond to your talk, though, I do want to share one bit of really good news that I'm just so excited about, I have to tell you all, and that is that today the Portland City Council voted to fluoridate the water system in Portland. Now, Oregonians like to think of themselves as very progressive and forward-thinking. Actually, Oregon, up until today, was 48th in the country with respect to coverage with fluoridated water. So, and far below Mississippi, I might add.
We're working hard on that.
So I think that I'm really, really pleased with that news. This is a picture of where I went on my summer vacation. It's called Hurricane Creek in northeastern Oregon. Very beautiful place. I'm not going to tell you all the details. You have to hit me up at the reception in a few minutes if I ever stop talking, if you want to hear more about that. But this is a very beautiful canyon, a chasm, really. And I guess I want to react to Dr. Marks with a little bit of caution and anxiety. You said, and I wrote this down, we have a medical care system that's ready to work with you. I might say we have a few leaders in the medical care systems in our states who are ready to work with us. We have a bunch who are being dragged kicking and screaming. It's really a challenge for us to bridge this chasm. So I don't want to be too optimistic and sunny about that. But it is a historic opportunity for sure, and I think one that is not likely to be repeated. So there's a lot at stake for us to be successful with it. I think one of the aspects of this chasm is really, and you kind of referred to this in your talk, the kind of prevention that we're talking about. Clinical preventive services, they're required in the Affordable Care Act. That's going to go forward. Some of the individual community-based services are going to go forward, I think. I think that's where a lot of the movement has been. Community health workers and some of the other programs. But, we all know that some of the most powerful tools we have are really the policy change tools. And I would suggest, with respect to Dr. Wallace, and by the way, he has not only an Iowa connection, but a very strong Oregon connection, so we can claim him as one of our sons as well. One of the most powerful tools we have really is policy change. Most of the examples that Dr. Wallace gave, and most of the examples, in fact, that in my own experience we've had of successful partnerships with healthcare systems have not been around those kinds of policy change issues. So I'll know we have real collaboration when I have the healthcare systems standing up with me and working on, I don't know, a sugar-sweetened beverage tax perhaps, or something that has something to do with regulating food marketing to children. These are very, very touchy issues politically because they involve government, they involved all of these values and so forth. So I think this is part of the chasm that we as leaders need to help bridge and keep emphasizing the potential benefits. Could we go to the next slide, please? One of the, we have a small health foundation in Oregon, Northwest Health Foundation, and they funded this study. Ken Thorpe from Emory University did a national study like this, and the foundation funded him to do one looking at Oregon data, the impact on rising medical spending in Oregon from 1998 to 2005. And what it found was that a third of the increase in medical spending could be attributed just to the increase in the prevalence of obesity in Oregon. One condition, okay? Now, if you were running a business and you had something that was driving your costs up 30%, I mean, that would be the first place you would look to do something to keep those costs down. And we know, of course, those are not things that are going to happen in the healthcare provider's office for the most part. These are things that need to happen in the community, those kinds of policy changes I was talking about. So a wise sage, that would be me, by the way, said this quote and keeps repeating this quote over and over again, that unless we address the drivers of the need for healthcare, like obesity, we're just not going to have a sustainable business model for our healthcare system. So I think that's a message we need to just keep reinforcing over and over again. Next slide, please. So this is a picture of me doing the presentation of our budget document to our Legislative Ways and Means Committee. And actually, I guess the right way to say this is the picture I try to keep in my mind of me, because I don't particularly like to get dressed up like this. But, you know, often, really, that experience is some kind of kabuki. It feels like kabuki. It's very stylized, and it's not really about me. Hard to believe, but it's really not about me. And I need to remind myself, and I want to talk a little bit about what it's like to be a show and a leader through these kinds of processes. And this is, I think, the first lesson. Next slide, please. And Jim, you will pardon me, this is not, I'm not trying to butter you up by showing a Johnson & Johnson product here. But the acronym, if you could just press the advance button one more time. Q-tip, quit taking it personally, I think is something that we really need to keep in mind. This is about our roles and about us being leaders around these very difficult societal and policy choices that really our nation is struggling with. Next slide, please. Now, the last thing I want to say, so I have teenage kids, and I've tried really hard to convince them that I am so uncool that I'm actually cool, you know? Even though I haven't been very successful at that, by the way, but even though I live on the West Coast, I'm not a surfer dude, okay? But this is another image that I try to keep in my mind as I think about the kind of leader that I want to be, and that's that I want to be ahead of the wave and ahead of the curve and skating, smiling, just like that little guy in the picture there, as we move forward. Now, I will tell you that the staff who work for me sometimes find this really infuriating, because by the time they are really deeply enmeshed in solving the problems that they have to solve tomorrow, I'm trying really hard to think about what's going to happen 6 months or a year from now and getting ready for it. And it's not because I don't respect or I don't care about what they're doing. It's just that I need them to do that so that I can do this other function. And really important, I think, to remind myself of that all the time. Now, in this context, the chief thing that I'm trying to think about, next slide thing, is this. What if they say yes? So we've elbowed our way to the table now with healthcare. We've gotten investments of trillions of dollars into the kinds of prevention activities we're going to have. Are we going to be able to deliver that? Or let me put it another way. What do we need to have in place so that we can deliver that? And I think that's something that we all really ought to give some serious thought to, because the very worst thing we could do is to oversell what we're going to be able to contribute to this problem, and then it's a dismal failure, and it'll be another 100 years before anybody looks to public health and the kinds of tools and approaches we would take. So with that, I'm going to stop, but please think about this question over the next couple of days. I think it's a very important one.
I'd like to react a little bit to your reactions. There are some great ones. First of all, you're absolutely right when I said that the medical care system is ready. Some are, many are not, probably most are not. That's also the way when we look at industry. And one of the most difficult things for government is to find and work closely with the champions, the ones that are the leaders, and not with the associations. But in fact, that's what you're going to need to do. That's one of the things that's going to be most important for you, because those champions will bring along the others in their sector. So we have a program called Child Obesity 180. Former CEO of a Fortune 500 company got very concerned about childhood obesity and came to us and said he wanted to bring together the public, the private, and the not-for-profit sectors to work on this. He had, to use an old term, but some of you will remember this, a Rolodex that didn't overlap with mine. And he called and got people to the table, the CEO of Kellogg, the head of the Restaurant Association, and others, to say what could they do, initially in a safe space discussion, but then more broadly. But he also thought about, and wrestled with, did he want it to be large or did he want it to be small with the champions? So we are seeing champions, and we've got to encourage those. So Disney, if you haven't been paying attention to those issues, said that it will no longer allow junk food to be advertised to children on its stations. They did that even though that they had a lot of things, that unhealthy food. They did that because they wanted to be on the right side of their relationship with mothers. They're a large company. They're a leader. They had already had healthy options as the default options in their theme parks. When they do that, they know the data. 60% of mothers choose the low-fat fruit with the sandwich Happy Meal equivalent. So I think it is finding those champions and blowing on those flames, elevating their role is the way we're going to get that done. And like Mary said, sometimes they're going to be our most effective spokespeople. The other, you commented about when they're going to get behind on soda tax or things like that. The Disney example is one on marketing, one of the most contentious areas relative to children. I saw a report recently that Baylor hospitals have gone so where they don't sell, or if they sell it, it's in a very limited set of places, sugared soda. And they sell in their hospitals. They sell Coke Zero and all of that stuff. That Boston doesn't have it in the vending machines in their public buildings. So I don't think we're going to get them all the way there, but I think we can get them further along. And finding those things, we all know if you're going to try to lose weight, you're not going to do it by skipping a meal or taking a hike. You got to do something a little bit. That's what we're going to have to get them to do. And then the last thing about your surfer cartoon, we all know that when you surf, you're going to risk falling off or even crashing onto the shore. But it's so important to get that thrill that you do it. And we've got to be able to take that risk too.
Thank you so much, and thank you, Mel, for your entertaining slides. And when I go do my budget presentation next week, I'm going to think of your kabuki person there, and it will help me. So are there questions for Jim or for Mel? Not for me? Yes. Here, you can have my microphone. Oh, there we go.
So, and this is to Jim, but I'm interested in your experience, all three of you. We certainly look at healthcare costs as costs, which are taken away from jobs, education, transportation. But there's another view of this that I've run into, and that where there was a community that I dealt with, it was their average cost for an ambulatory procedure was 400% more than a hospital down the road. Their utilization was higher. And when I suggested to the hospitals, when I was running the HMO, that we might be moving our patients 45 minutes to save that 400%, there was an op-ed in the paper which basically said every dollar we bring into this community is a job. Every dollar we bring into this community health care drives our economy, and that I personally was trying to ruin the economic viability of this county. So there is another side to this. These are real jobs today. How do we make that transition for the legislature that that's their district, with jobs from the CEO high paying through unskilled jobs, that is in fact the major employer in their community, that in fact there's another way of looking at this, and if they were healthier, they might lose some income and jobs in the healthcare side, but they might pick up a manufacturing plant.
Paul, that's a great question. It's one that the tobacco industry used to use as well, that we had people on the farms and all of that growing tobacco, and that both the net value is still in having people be healthier. The other part that I would say is, in fact, those costs are driving out, and those jobs are driving out others. So that's why jobs are going overseas. Now, you looked at Taiwan. Taiwan is, relatively speaking, a fairly expensive country, and it's a quarter of our costs. And in fact, we think of medical tourism, and the x-rays are being read in India. We ought to think of that as outsourcing our health jobs. That's what's happening. We're outsourcing our health care jobs. This is not a viable system the way we have it. And then the other is that those are costs, that if you're a developmental economist working in the developing world, there's two ways you invest in people: education and health. And it's so how do we know the cost of illness we don't know the value of health. So New York City says now that they think that they've increased the life expectancy 3 years there over the last decade, at least twice as fast as the U.S. as a whole. What's that worth to the city? What's that worth in economic value, economic development? We're actually going to try to see if we can't study that. There are some economists that look at it big picture. We've not done that very much in health. Regulatory agencies have to value a human life as they do the cost effectiveness on their regulations. An economist named Kevin Murphy and I think it's Robert Topol in the University of Chicago said, if we could have a 5% reduction in cancer mortality, that would be worth $500 billion a year to the nation. We have had much bigger reduction than that over the last 2 decades, with tobacco reductions being 40% of that reduction. Cancer mortality, age-adjusted, has fallen 1 to 2% per year since the mid-1990s. We have not gotten any recognition for the tobacco role. And clearly, even the treatment value is tied into increased screening. We ought to be able to make that case for ourselves, for the notion of prevention, for the nation.
I want to add to that sort of a tactical comment. We've done a lot of, I think, quite interesting and innovative health reform stuff in Oregon, and right now our work is really focused around Oregon's version of accountable care organizations that are called coordinated care organizations, that all of the Medicaid dollars for these areas are being funneled through the CCOs. They have a global budget, and they're going to have to get engaged in prevention if they're going to be able to manage to those budgets. At some point, the light bulb is going to go on about that, if it hasn't already. In one of our communities, kind of as a pilot leading up to the CCOs, it was actually not far from the picture of Hurricane Creek I showed you, small rural hospital, Frontier Hospital. They did a great job with the primary care docs in the area, creating medical homes for people and keeping them from going to the emergency room. Everybody thought this was the greatest thing. And then all of a sudden the hospital caught on to what was going on, and they said, whoa, wait a second, we subsidize all of our other operations with the extra revenue we're making from the hospital. This can't go on, or we're going to go under. Now, that is a very real issue for that community. And I think one of the smartest things about the way we've approached this CCO discussion is that the governance of this, the decisions about those choices, are being made at the local level. So nobody can write an editorial in the paper about the big bad state that's coming in to do this to them. These are choices that, and trade-offs that the local folks are going to have to make, and solutions to this transition are also going to have to be found locally. That doesn't mean that the state isn't going to help in any way we can. Of course, in fact, that's our primary charge. But I think that local function where people look each other in the eye and have to be accountable for health and the other things that are going on in their community, I think that's a really powerful force in this whole process that really we should be harnessing very aggressively.
So are there other questions? I have a question. So a lot of the return on investment, although you've said and shown us some things that were short term, a lot of the return on investment around chronic disease is long term. And we've got legislators and other policymakers who are more interested in what's happening right this second before the next election. So is there a way we can address that?
I think that that's a challenge. I actually think Paul's is a big challenge too, especially for smaller communities, the issue of the jobs. The short term is a tricky one. There are places where it happens. So I mentioned clean indoor air laws, smoking reductions that have value in heart attack, cardiovascular disease quite quickly in a few months, few years. That's actually a place where I think business can help, because while they're looking in their worksite health promotion, they can take a 3 to 5 year time horizon. If they're looking to move to an area, they're looking at more than a 6-month time horizon. So for the governors, it is, they've got to balance their budget now. That's a real pressure and a real challenge for them. But for creating a business climate, businesses can have a longer horizon if they can become an ally for us in this work. And they can probably help insulate a governor from longer-term decisions that are important. But I'm sure they spent several years trying to woo VW to Chattanooga. It took them probably a few years to build that plant before they had it constructed. And if you don't know, VW also built a very large wellness and fitness facility that they opened up to the community as a whole, because they realized how important it was to be in and part of a healthy community. So I think that that's one of the values we ought to try to capture from business.
Yes.
Hi, Denise Koo, CDC. I've recently learned from David Fleming that CDC also stands for something else, Community Development Corporations. And he said that we in public health should be taking advantage of those because they have money and they want to invest in something that's going to get a return on the investment. I don't know, Jim's nodding. If you could comment on that, or if anyone else could comment on whether they've tried to leverage this and how that works. I'm just interested.
I could. It's an area that I didn't put in my talk at all. We had a commission to build a healthier America, to look at what things that were beyond medical care that were really important, that were practical policy solutions. Unbeknownst to us, the Federal Reserve Board of San Francisco, which leads all of the feds in community development, saw that report and then devoted a whole issue of their community financing journal to community development and its health value and health effects. They then did it for their practitioner journal. They've had 2 national conferences on it, all the feds, where they brought in the community development corporations. The community development financing institution is the other key term. A number of the regional feds have had it. Dallas has had, I think, 2 meetings. Is that right, David? I think 2. And Minnesota is going to have its second. Boston has had one. New York, San Francisco, LA, others around the country. They bring in, they help direct about $40 billion a year in the anti-greenlining laws and things like that. They can put in sidewalks, pocket parks, clinics, supermarkets, charter schools. They never thought of health as one of the outcomes they should track. Of course they knew that if it was better housing, it might lower asthma rates and things like that, but they never thought of how to do that. So we're actually working with them and a couple of the community development financing. We're going to try to get a consortium of foundations to put up, take the 8 largest, if we can, leading community financing institutions, the one that the others follow, and try to set this up in areas around the country and get a standard way of doing the health metrics that are going to have to be simple. These are practitioners, these are financiers, not scientists, but they've got to be relevant to health. So we're looking to do that. It's an incredible, it's taken off so much faster than we thought. I asked one of the women who heads one of these organizations, why has this caught on so quickly? She said, we knew all along that we actually had only a partial solution. Health is giving us a lens to say this is what it's about. It's about people having places that they feel good about for their families, getting to know their neighbors and all of that. And it dawned on me that we in health had also been only thinking of a partial solution when we think of health care. That what people want is not health. They want a good life for their family, themselves, jobs that are meaningful, being able to get to know and play with their grandkids. Health is a crucial base that gives them the best chance to have that kind of life. But that's the life they want, and that's what we're seeing community development come along with. So I thank you for asking that, because it's been one of the most exciting things we've gotten involved in. Ben Bernanke is talking about it, if you don't know. He's talked about early childhood very specifically and the investments there.
So we have time for one more question. Yes.
I think I'm on now. Henry Anderson, Wisconsin. Most people haven't been identifying themselves, but I will. We're the beer, brats, and obesity state. So, and we have talked to a lot of our businesses, and the question, Jim, I'd have for you, what resonates with a lot of them is the productivity reduction that these things have. Now, the healthcare costs, they're very concerned about, but most of them manage it through insurance.
Yep.
So my question to you is, are you working at all with the insurance companies? Are you able to convince them that if companies were to take certain actions, they would give them a reduced insurance rate? In Wisconsin, our managed care people are very aggressive at trying to get their clients, as it were, give them reductions for why, things like that, because it then saves the healthcare system money and it increases, hopefully, their profitability. But what we're really after is, if you want to encourage business, it's what can we do so that the insurance companies will be able to look at these programs and say, yes, those are going to reduce our health costs in the short term or whatever, and that in fact they will then take that into account in putting their profit or their proposals together. Most of them are not prepared to do that. So it's the general population in your state that governs the insurance rate, not the employees of your company. And I think that's where we somewhat have a disconnect.
I'm not quite sure if I'm getting your question, but let me respond in a couple of ways. First of all, for those of you who don't know, it was Reed Tuckson who helped have that happen with United Health about the Ys and their interventions. Increasingly, the insurance companies are sort of like our mortgage servicers. That is that they don't make the profits; they make it an amount off the top. So if costs go down, their profits don't automatically go up. So it really is on the business, and businesses are finding that it is saving them money. In Texas here, there's a grocery store chain called, I think it's HEB or HEB, and they've taken this on in a big way and seen their growth in healthcare costs slow to dramatically less than what they see in the industry as a whole. So I think it is at the business level, less the health insurers. The health insurers will offer these kinds of services if they think it gives them a leg up in getting businesses to sign up. And they can do it and they can make a case that'll help those businesses manage their costs. But that's the way we're seeing it. One of the things we are doing, as you know, we've taken the Wisconsin County Health Rankings model and taken that more national so that all the counties would have it, because we need to make some of these issues local. We need to, like all politics, all public health is local, and we've got to have the community broadly interested in their healthiness as a place to live.
Thank you so much, Dr. Marks. Jim, I appreciate it. And Mel, thank you for your insights. I appreciate that too. So if y'all would thank Dr. Marks as well.
Thank you.
Now I know you really want to get up and run out of here, but I have a boatload of announcements. Don't forget to fill out your blue evaluation form and place it in the box outside the door as you exit. Pink. Okay. Yeah, pink, blue, whatever. We'll reconvene in this room tomorrow at 9 for our session focused on the President's Challenge. Current and former shows are encouraged to join the Alumni Society breakfast sponsored by Blue Cross Blue Shield of Texas. The breakfast is at 7 in the Foothills 1 room on the 17th floor. 7, okay. All other conference participants will have breakfast in the foyer adjacent to this room. If you're interested in CEUs, we have medical, nursing, and public health CEUs. Check in at the registration desk for that. And now for the fun stuff. I invite you to reconnect with your colleagues at the annual networking reception. We'll start with food and drinks at the Iron Cactus at 6, followed at 7:30 by a private show at Esther's Follies. I have no clue, but it sounds wonderful. It's down the road. If you prefer, you can take a shuttle to the Iron Cactus. Please meet in the lobby for those. The first shuttle departs at Okay, so the first shuttle departs in 15 minutes, and then there's another one after that. Although if you want to, you can walk, right? And we'll meet in the lobby in 15 minutes. Okay, and 30 minutes. Okay, I'm learning sign language. Esther's Follies is 2 blocks from the Iron Cactus, so we'll walk over there from the Iron Cactus. Shuttles will be available for the return trip to the Hyatt. Thank you for a great first day, and I look forward to talking to you this evening and drinking. Yes. Sorry. Red wine, yeah. Oh, yeah, good.
Sure. So Esther's Follies is a pretty famous place here in Austin. It is political humor. It is very in-your-face political humor. The legislature goes down there each year before the legislative session. Put your political association aside. Be ready for. Again, so if you couldn't hear me before, Esther Follies is a very famous club here, political humor, etc. It is a place that the legislature goes before each legislative session. And again, they will be equal opportunity political offenders. And so beware for a pretty, I always find it hilarious. And so I hope you have a great time.
Thank you all so much, and thanks to the ASTHO staff for everything they've done today. Thank you.